and they basically quantify the amount of care provided. Now you can see the numbers for the codes here, 99281 to 99285, which correlates with levels 1 through 5. And then there's a 99292 for critical care. And again, payers use these codes when determining how much reimbursement or how much to pay for a given encounter. Another thing that you guys probably have heard is the ICD-10 codes, or International Classification of Diseases 10th Revision Clinical Modification Codes. Very glad they abbreviated that. The function of these are basically used to kind of track and report medical diagnoses for epidemiological tracking. And lastly, some of you guys have probably heard us talking about RVUs, or the relative value units. And this is kind of your basic unit of productivity. So each CPT code is worth a fixed number of RVUs. A lot of times payers will only get the CPT code and the ICD-10 diagnosis when they're determining how much payment or how to reimburse for an encounter. So the way to remember this is ICD codes are diagnoses, and CPT codes code for the work done. There we go. Again, so payers use the diagnosis captured by the ICD-10 codes to determine the payments. So for example, if you saw a patient and diagnosed this patient with acute tonsillitis, that might have an ICD-10 code of J03.90. That won't be on the test. And there'll be a CPT code of 99283. So in this example, the payers will pay up to a 99283 for acute tonsillitis. However, if your chart has missing elements, say you missed something in the history or you didn't have enough physical exam, this chart then can be downcoded to a 99282. And of course, payers will gladly pay less for that encounter. Conversely, if you document a bunch, you have a ton in your history, a ton of physical exam, or very complicated medical decision-making, but your diagnosis is still acute tonsillitis, the most that chart can be billed out for is still a 99283. The interesting thing is, so if you saw this patient and their tonsillitis was severe enough to cause dehydration, or maybe they've got an AKI and you need to give them some IV fluid, if you include those diagnoses in your chart, things like dehydration requiring IV fluid may bill out as a higher code. So that might actually be in 99284. So that chart may actually bill higher. So make sure you put in all your diagnoses. In general, to bill any code, the services furnished must meet the requirements for that code. I guess the one caveat to that is, so let's say, for example, you're taking care of somebody who's having an NSTEMI. You don't need to go ahead and put chest pain in as a diagnosis. But otherwise, you really do want to include any other relative or relevant diagnoses. So here you can kind of see the breakdown of RVUs per level. And again, this bottom one is critical care. Can I get rid of this? Okay. So your productivity is essentially the number of patients that you see per hour times the number of RVUs per patient. Or if you do the math, that's basically RVUs generated per hour. So if you're going to increase your productivity, you either must increase your speed or your RVUs per patient. If you take a look at this chart, you'll notice that downcoding a level 2 to a level 1 or a level 4 to a level 3 essentially cuts your RVUs in half. If you're downcoded from a level 5 to a level 4, that's like seeing an entire another level 3 case. Critical care to a level 5 downcode isn't a huge deal. It's like seeing another level 2 patient. But if you don't have enough in your chart to justify a level 5, then maybe you'll be downcoded to a level 4. And that's a big drop from critical care down to a level 4. It's like seeing an entire another level 4. Yeah. Depends how good your triage staff is, really. So it's a totally different system. The ESI codes are triage codes. So when people arrive, you know, they're, oh, this person's sick, this person's not sick, oh, this is another abdominal pain, they get a 3. Somebody could theoretically come through and be triaged as not sick, but then you find out actually that they've got sepsis. And so maybe they're a level 5 or a critical care. So unrelated, but there may be a correlation if, you know, everybody's kind of on the same page medically. Did this thing die? Ah, perfect. Okay, so let's take a look at 2 recent ER grads, both working in the same emergency departments. And just to make the math easy, let's say they both see 2,000 patients over a year, and all of their patients are level 5. Doc A nails her charting, and she has no down coding. So 2,000 times 3.8 RVUs is 7,600 RVUs on the year. Doc B isn't quite as good, misses some past medical history or some elements in her history and physical exam on half the charts. So that actually comes out to be about 6,360 RVUs over the year, or a difference of 1,240 RVUs. So just for example, if that emergency department's bonus schedule is $20 per RVU, then Doc A makes about $25,000 more that year than Doc B. Or another way to look at that would be Doc B would need to see another 330 level 5 patients to make up for that difference. So in general, the more complex the visit, the higher the level of the code, right? So if you're admitting or transferring somebody, start thinking level 5 chart. If you're sending somebody up to the ICU, you should probably be thinking critical care. Here's kind of a general breakdown, right? So the 99281 is very self-limited things. 99282 is a very low to moderate severity. 3 is moderate. 4 is worse than moderate, but still not life threat. And 5 is higher severity, things that may actually become a life threat. On the next slide, I've got some examples here. It's kind of a big and busy slide. But so if you look over at level 1 here, you see things like wound checks or med refills. Level 2 would be like a contusion. Somebody has a bruise and you don't do any x-rays. URI with no systemic symptoms like a fever, a rash that you're not doing anything about, insect bites and so forth. Level 3 would be something simple like a UTI or a well-appearing febrile baby. Somebody comes in for nausea, vomiting, diarrhea, and you don't have to do anything tests or medication-wise, or a strep throat, low-grade headaches, things like that. A level 4 would be something like an asthma that gets up to 3 nebs, non-cardiac chest pain, so that's chest pain that only gets an EKG and a chest x-ray done, no troponins. Abdominal pain with labs or labs and imaging, headaches that you give medications to, or essentially any significant injury that's requiring a workup or imaging. Level 5 would be an asthma exacerbation that's more severe, needs more than 3 nebs, cardiac, chest pain, peritonitis, altered mental status. Another thing, level 5 is anybody who you're giving IV opiates to, because IV opiates require constant monitoring. I think that's kind of a big surprise for some people as they go through the course. So as we were mentioning, each CPT level has a minimum list of things that you have to include in your chart in order to meet that CPT level. And if you miss any of those elements to that chart, then the chart is downcoded to the highest level that your chart meets. Does that make sense? Good, okay. So in general, I think it's good to err on including too much information that may help avoid some downcoding. And again, if you put everything under the sun into this chart, it will not be upcoded because that ICD-10 code only equals a certain CPT level. And then keep in mind that coders are not allowed to infer. Yes, yeah. So you'll never get in trouble for having too much in the chart, but if you don't have enough in the chart, you can be downcoded. So yeah, error on including too much information. Oh. But I use Dragon. Dragon did this. I don't know. Again, if it wasn't documented, it wasn't done. You can try Jedi mind tricks, but you may end up like Captain Jack Sparrow. Sorry, 2020 was like the year of memes. I had to. So why are we charting? I've kind of been talking a lot about CPT codes and RVUs, but it's more than just for physician and hospital reimbursements. This is also how we preserve and disseminate details from our patient's ER visit, right? So if you see somebody for sinusitis or a PTA and they're following up in Dr. Lasavio's office, this is how Dr. Lasavio knows what we did and what we thought about the patient. Also in lawsuits, the chart is typically and oftentimes the only kind of representation of what occurred during this encounter. Hospitals also use your chart for quality improvements, and administrators oftentimes use these medical records to figure out points of delay in the emergency departments. And a lot of good research studies actually start out with some retrospective chart review. That's why a chart is not the place to get into disagreements with consultants and things. Anything that you put in the chart really will be kind of interrogated. I've been deposed once, and actually it was a fun experience, I thought. But I think that's because I wasn't on the line. But yeah, and it actually was during COVID, so it was over Zoom. I imagine it would have been a little more intimidating if I was in this room with all these lawyers. But they went line by line and asked me every single thing in the chart that they didn't understand. And they asked me to probably explain a lot of things that they did understand, and they were trying to kind of trip me up a little bit. But anyway, moving on. So how much do I really need? Here you can see the different levels of charts. This is the number of elements required in the HPI, the number of parts to the review of systems, the number of past medical, family, social history. As an aside, your surgical history is actually just part of your medical history, even though we oftentimes separate it out in the chart. From a billing coding standpoint, that's all part of your medical history. And then here's the number of systems you need in your physical exam. So as you guys, I'm sure have heard, right, the elements of your HPI, quality, location, modifying factors, associated symptoms or negatively associated symptoms, severity, duration, timing, context. I'm sure you guys are familiar with most of those. For the past medical, family, social history, you need to document one thing for each of those for it to count, or you can say none if somebody has no past medical history. For each review of systems, each system needs one entry or the word negative for that to count. It is allowable to say the pertinent positives are included above in the HPI, or you can list them down here under the review of systems. But you must say a full 10-point review of systems was performed and the remaining systems were negative. Saying a full review of systems was performed in negative actually means that you did a full 14-point review of systems. So you want to be very clear about that. And then I've also read about some courtroom issues where the quote 10-point review of systems is negative other than above was what was in the chart. But then in the HPI, there was no mention positive or negatively of what those questions might have been. And so there was really a question in the courtroom as to whether or not the doctor had ever asked those questions. So if you're saying it's included above in the HPI, make sure you include it above in the HPI.
One of the things I've noticed that doesn't actually help. So when I'm signing your chart, but just be careful with your notes. All you have to pull in is there, but if it just says not on file, not at, not actually there.
That's a good point. Yeah, I couldn't quite hear you, but I think you said if the entry is no past medical history, then that's allowable. That's basically saying the nurse asked and the answer was no, and that populated the chart. When in doubt, you can always just say reviewed. For physical exam, you actually need at least 2 findings for each system. It doesn't matter if they're positive or negative or both, but at least 2 findings for each system. And then if you guys have done any reading on charting, which I'm sure everybody has, it's really exciting. They actually talk about you can document the physical exam either by systems or body regions. And I actually recommend never using body regions, just be in the habit of using systems. Because to reach a level 5 chart, you have to use the body systems. So if you use body regions sometimes and you mix it up, you could be getting downcoded or missing some RVUs if you do that. And the systems are constitutional, eyes, ENT, cardiovascular, respiratory, GI, and GU are separate. Musculoskeletal, skin, neuro, psych, heme lymph, neck, and chest. And it's weird. I know neck and chest are body regions, but they're actually also included in systems. For constitutional, in your constitutional section in your charting, one of the first lines should be nursing notes and vitals reviewed. That's one of the entries for constitutional, and then the second entry for constitutional can be whatever your patient looks like. Here we go. So the MDM is really what's going to determine the level of your encounter. But again, if you have up to a level 5 MDM, but you only have 2 or 3 parts in your HPI, then the max that your chart can be is now actually only going to be a level 4 or a level 3. Right? So you can be downcoded if you don't hit the requirements in the rest of your chart. But the complexity of your MDM is really kind of what determines the level of the chart. And again, if it wasn't documented, you didn't think of it. But this is kind of where you'll document the patient's course. You want to discuss any test results. Really what you want to do is discuss any positive test results and any negative test results that guide your decision making. You also want to talk about different interventions or why you did not perform certain interventions. Just listing test results doesn't count, right? So if you just say, patient's creatinine was 2 and the hemoglobin was 7.5 when admitting this patient, the coder doesn't know that you're actually admitting this patient for AKI or for anemia, right? So what you would want to say is, patient has an acute anemia, but CKD or chronic renal impairment. This is really the section where, kind of as you're reviewing your labs, you're really just kind of working through your differential diagnosis. So that should kind of come out in your MDM. Basically, discuss or talk about what you think is going on with the patient and why. Talk about anything that was abnormal. You pull in or talk about abnormal physical exam findings, for example. So, if we had a heroin addict come in for chest pain or shortness of breath, and I heard a new murmur and they had a fever, my discussion would also include, I think this patient has endocarditis because they've got a fever and I hear this murmur, that sort of thing. You want to make sure that you mention all of the likely diagnoses, but also the can't miss diagnoses. And if your MDM supports a level 5 chart, but again, you only have 3 elements, then again, you'll be downcoded to a level 3. This is also where you'll talk about different treatment options and contraindications. If you're doing anything that is a deviation from the standard of care, it's very important that you kind of put it in here. Again, if something, God forbid, bad happens to your patient, one of the things that lawyers will be looking for is deviation from standard of care. And so you can kind of protect yourself here if you discuss why did I not give TPA to this patient who had stroke symptoms, for example. You also want to talk about secondary problems, different things that would increase your patient's morbidity or any treatment complications, and discuss how this has affected the patient's care. Right. So for example, if I'm taking care of a patient with chest pain, I want to be very clear that I'm taking care of a 65-year-old with diabetes, hypertension, and hyperlipidemia. That increases the risk of this case. If you talk to any consultants, you want to talk here or discuss here about what the consultants recommended. And then always be sure to document the patient's condition, diagnosis, and disposition. If you have multiple diagnoses for your patient encounter, the first diagnosis actually should be the main condition that you are working the patient up for. So that's that tonsillitis or acute pharyngitis, and then the dehydration and AKI would come in underneath that. And then when you're choosing your diagnoses in the emergency department, everything is either acute or an acute exacerbation of a chronic condition. In general, decisions based solely on the history and exam require minimal information, and that kind of will be obvious in your MDM, and that will be kind of scored down as a lower chart. Cases involving chart review or performing a lot of tests and imaging are credited for increased complexity in the MDM, and as a result, increased RVUs. If no specific diagnosis is found, like appendicitis, for example, it's okay and actually recommended to use a broad descriptive diagnosis like abdominal pain. It's better not to be wrong, and using that kind of broad descriptive diagnosis allows or keeps it open for further potential diagnoses. And again, include all diagnoses that you can come up with. So for example, somebody who comes in for vomiting and abdominal pain, my diagnosis might be abdominal pain, nausea, vomiting, dehydration, AKI, if I find that. So go ahead and include all those in your diagnoses. I have never diagnosed somebody with gastroenteritis. One, you have to be vomiting and have diarrhea, so it's most often actually incorrectly used, but it's the #1 diagnosis on, or it might be top 3 now diagnoses on missed appendicitis charts. Good question. Yeah, I've never really thought about that. I didn't see anything that stipulates that it has to be directly related. I think it's very helpful, for example, if you have a chest pain and you go back and you pull up your last cath, for example, but a lot of times I guess I'll put in the most recent discharge summary if I can find that, or just a little summary of the discharge summary, and that may or may not be directly related to kind of what's going on. So you get credit just for pulling in and incorporating the old information that you find. Great. This is our our orthopedic colleagues. And so when they're scoring here, I'll read this because it's kind of blocked. So MDM is coded based upon the 2 out of the 3 highest or most common elements, and these are the 3 different elements of your MDM. So the first is the number of possible diagnoses and or the number of management options that you had to consider when taking care of that patient. The amount and or complexity of data analyzed, including medical records, diagnostic tests, and other information and sources. So you always want to make sure you include what history you get from family or EMS. That actually increases the complexity of your MDM. And the risk of complications, morbidity, and mortality, as well as any comorbidities associated with the patient's presenting problems, the diagnostic procedures, and again, the management options. If we break this down a little bit farther, the number of possible diagnoses or management options to consider is based on a couple different. The computer up here died, but I think I'm still there. Oh yeah, I think Harrison told me that. Thanks, man. Anyways, the number of possible diagnoses or management options is based on the number and types of problems addressed during the encounter, the complexity of establishing your diagnosis, and different management decisions. It also includes the number and type of diagnostic tests. And this may be an indicator of the different or the number of possible diagnoses. And so coders kind of use that to infer the complexity. And the need to seek advice from other healthcare professionals or get consultations also indicates a higher complexity. I might have been too ahead. The amount and or complexity of data to be reviewed is based on the types of diagnostic tests ordered and reviewed, right? So a decision to obtain and review old medical records and or history from other sources is included here. If you discuss any contradictory, abnormal, or unexpected test results with a physician who performed or interpreted the test, this also increases your data complexity. So actually here at Rush, I think this most often comes into play when I have trauma cases. I look at a lot of my plain films. Sometimes I think residents, earlier residents don't have a lot of, or radiology residents, I should say, don't have a bunch of trauma experience. And every once in a blue moon, I think a fracture slides through. And so if I see maybe a little finger fracture, I give the resident a call, talk it over with him. Sometimes he tells me, no, I'm an idiot. That's just a nutrient vessel. Okay. And sometimes he's like, there is a little chip fracture there. So I document that in my chart, and that actually has increased the level of complexity of that case. And this also includes if you do a read. So whenever you guys, and this is actually a pretty common thing amongst your charts, and it's because your attendings are documenting your EKGs. But performing an EKG, just the EKG in and of itself counts as a diagnostic test. So that's scoring you a point in that other part of the MDM. Now, also, if you're entering your read of the EKG, that's you now interpreting this test. And so in a different part of the MDM, that's also increasing the complexity. So very, very important from the day you graduate moving onwards, make sure that all of your EKGs are documented in your chart. Does that make sense? Yeah. I don't think most of us do, but the person who, whichever attending is seeing that patient primarily is documenting that EKG. But it's, yeah, I think a lot of us probably would, but it's just too busy up there for us to actually read these EKGs. Most of us are just, it's not a STEMI and it doesn't look like this person's about to die. On to the next one. Lastly, the risk of complications, morbidity, and mortality is based on the risks associated with the presenting problem, the different diagnostic procedures that you must perform, and the risk of the treatment options. The assessment of risk of the presenting problem is basically, it's based on the risk related to the disease process anticipated between this encounter and the next encounter. Good, this did kind of come through. Yeah.
Simply saying this is a normal.
The answer is no. You would get some credit for having done EKG as a test, but you wouldn't be getting credit for the read, nor would you get EKGs also, interpreting an EKG is also actually a procedure. And so when you put your interpretation in, you're also generating separate RVUs for an EKG, and it wouldn't count for that either. In a couple minutes, we'll discuss actually what you need to put in. I have that kind of towards the end. This is a table of risk. Unfortunately, the things are missing. So when the coders are using this to kind of guide how they're scoring your MDM, they basically just use whatever the highest risk out of any of these columns is. I'll give you a second if you want to take a look at some of the examples up there. Can everybody see that? Oh, yeah. You're old, Dr. Gore. That's why. Yeah. Here we go. And this one didn't really, this one didn't come out very clear. This is just a slide kind of summarizing for each of the levels what's required. But all this information has been already included previously in the lecture. Okay, does anybody have any questions on regular billing before we move on? Regular charting, I mean. Okay. I think a lot of people have questions about critical care. And this is a very busy slide. However, this is literally in quotations from Medicare. So I think you just take a second to read this and digest this, right? So critical care is the direct delivery by a physician of medical care for critically ill or critically injured patient. A critical illness or injury acutely impairs one or more vital organ systems such that there is a high probability of imminent or life-threatening deterioration in the patient's condition. Critical care involves high complexity decision-making to assess, manipulate, and support vital system functions, to treat single or multiple vital organ system failure, and or to prevent further life-threatening deterioration of the patient's condition. I don't think there's any other better way to put that than how they put it themselves. So failure to initiate these interventions on an urgent basis would likely result in sudden clinically significant or life-threatening deterioration in the patient's condition. Of note, critical care pays 33% more, or is worth 33% more RVUs than the 99285, and there's much fewer documentation requirements. In the relative scheme of things, I think critical care is vastly undervalued for us. If you're an ophthalmologist and you do a cataract removal, that procedure takes 7 to 10 minutes, and it's worth twice as many RVUs as critical care. But when you're performing critical care, you're saving somebody's life or somebody's organ system, possibly even saving them admission or preventing them from going to the ICU. So it's a very valuable service, and I don't think we should be scared about firing off critical care procedures. I actually think as a group, that is probably the most underutilized thing. Well, we'll get to the state averages in a little bit, but our average of billing for critical care is about half that of the state. And although we don't see a lot of people rolling through the front door, getting chest compressions, maybe less than some other hospitals, a lot of our patients showing up actually would qualify for critical care. All right, look at this guy, which kind of brings up my next point. He looks pretty chill for being intubated. But you no longer need abnormal vital signs to qualify for critical care. So I don't know, this guy might qualify. So if you look at this, right, there is a high probability of sudden and clinically significant or life-threatening deterioration. You don't have to have tachycardia or tachypnea or anything like that. Requires the highest level of physician preparedness to intervene. I'd say when all of us walk through the front door to come to work, we meet this right here. And involving direct personal management, the absence of which would likely result in sudden, clinically significant, or life-threatening deterioration. I think that's just a really long-winded way of saying, what's the potential for decompensation? If that probability is high, then maybe think critical care. The fact that you knew what to do, or that it was easy for you to take care of that patient, and that the patient got better, doesn't mean that it wasn't a critical care case. So critical care, unlike a lot of other things we do, is actually a time-based procedure. And what you want, or what you're looking for, is the aggregate amount of time must be greater than 30 minutes, and that's in a single calendar day. Medicare has defined the first time slot of critical care as 30 to 74 minutes, and it's coded using this code. If your case is less than 30 minutes, then it does not qualify for critical care. So those people who come in and PEA arrest and we do 10 minutes of CPR and we pronounce them dead, that's not going to be a critical care case. It'll be a level 5 case. The problem is that may be a difficult case to have all of the elements that you need to justify for a level 5. And if you don't, then you'll be downcoded farther. So just keep that in mind. And again, the clock resets at midnight. So if you have a patient and you perform 30 or 40 minutes of critical care on the first day that they're there and they're still in the ER, and the next day you perform another 30 minutes of critical care, put in 2 critical care notes, because both of those actually qualify for critical care. Yeah.
So I was told first I came back from the CPR anyway, but the piece that extended was the kind of
I've not been told that. Actually, I think what I found was in the reading was that if you don't have the information to justify the level 5, it'll be further down coded. It's actually, I wonder if our coders could, I should ask our coders that. Interesting. The time that you're counting for critical care must be directly related to the patient's care, whether that time was spent at bedside or somewhere else in the emergency department. Time spent out of the ED does not count because you're not readily available for that patient's care. Here we go. And this is just kind of a visual breakdown. So your first 30 to 74 minutes gets billed out as one critical care unit. And if you keep going, it's additionally billed out by these 30-minute increments. And so you just keep on adding these 30-minute increments as your time goes on. Really, as ER physicians, we should, hopefully we're not down here, unless all the ICUs are full. So these are the activities that you can count towards your time when you're counting up your time for critical care. This would include time spent in the emergency department reviewing different test results or imaging studies, discussing the patient's care with other medical staff or family. Any time that you spent charting or documenting also counts as critical care, even though you're not at bedside. If the patient's unable to give you information or you have to talk with the family, any DNR discussions about patient's prognosis or testing, all of that actually also counts as critical care. But time spent on activities that are not directly contributing to your patient's care, even if you are in the ED, would not count. It's kind of common sense, right? If you're taking care of somebody else or you're on the telephone with a different doc talking about someone else, that would not count as your critical care time. And here's a table of some procedures that are bundled into critical care. So all of these things count in your critical care time. Some of these things are separate, right? So he was talking about CPR. CPR is a separate procedure, so that would be billed separately than critical care, and that would not count in your critical care time. Same with some more common ones, like when you're intubating or putting in central lines, the time spent doing those procedures does not count for your critical care time. Does that make sense? It's down here, right below. It got cut off. So this is, sorry. Oh, so sorry. Transcutaneous pacing here, cardioversion, EKG interpretation, those types of things are over here. Sorry. I do it here. A lot of times if I take sign out on somebody and I'm the 10 or 11 o'clock shift, if that patient's critical, or if I'm performing more critical, whatever, if I'm doing critical care on that patient for another 30 minutes on the next day, I'll put in a little procedure now. That would be the same calendar day. So we're no longer able to aggregate time amongst providers in the ED. It has to only be you. So I can't come in and work with Dr. Heinrich. And this is if our care is taking place at separate times during the day, or if him and I are working together, since we're in the same group, only one of us can bill critical care and only one of our times count. Unfortunately, resident and medical student time doesn't count at all. And time teaching or doing other things does not count as time for critical care. But if I'm taking care of a STEMI patient and the cardiologist comes down and is taking care of the STEMI patient in the emergency department, we both will be billing critical care because we're two different types of physicians. Yes. And there's actually a really weird situation where if your patient doesn't come in critical, even if you are the same physician and they become critical later on while they're in the ED, you can actually bill critical care plus the level of the chart. But yeah, if you're taking my sign out and my patient right now is fine, I'm like, yeah, this is just low risk chest pain, don't worry about it. And I go home and my patient ruptures an aneurysm, and you're like, go ahead, bill critical care. Yeah, you should. Here we go. All right, so I think you might have heard me mention earlier, critical care has much less when it comes to requirements for documentation. And so there is no amount of HPI review systems, past medical, family, social, or exam content required. Doesn't matter what you put there. If this is a critical care case and you have the appropriate critical care documentation, coders just kind of skip over all that. But you have to make sure that your chart supports the amount of time that you said you spent on the critical care. And it must show that the patient had an immediate potential for clinically significant deterioration. Just keep in mind, these patients most often are going to the intensive care unit or sometimes expire. And when you're documenting this, what you want to do is write a procedure note describing your management and the amount of time. You want to describe the patient's critical condition. You want to note which systems were in danger of failing. And you want to note the disease severity and other potentials for decompensation. And then again, always discuss and interpret the abnormal tests or vital signs that helped you come to this conclusion. So again, vitals might be stable and the patients may still have an immediate potential for life-threatening organ failure. It's possible that critical patients receive care that prevents deterioration, such that the patient may later be discharged home. First examples that come to mind would be like a bad asthma exacerbation or maybe a heroin overdose. They could be critically ill when they come in and you might be discharging them 3 or 4 hours later. Yeah, that's another great example. You always, in your documentation, again, want to include comments about the patient's progress over their course while they're in the emergency department. Document any responses to your interventions, as well as include different vital signs with your investments, or I'm sorry, with your reassessments. A lot of other things that are required in this chart, actually with EMRs, are kind of done automatically. So you need documented drug therapy start times, routes of administration, and all of your test results, your diagnostic test results. Epic is recording all of that and puts all of that into your chart automatically for you. This may be another one that's kind of difficult to see. This is just a list of common things that typically would indicate critical care. And these are just a list of different interventions. Or if you're doing these things on your patients, you might be wanting to think critical care. Oh, is that hard to see all the way in the back? Dr. Gore, did you bring your glasses today? Yeah.
So for somebody, they're valuing that. Don't tell me that second.
So there has to be a risk of organ system failure. So if they come in and you work them up for a AAA, but they have no problems at all, then there's no risk for imminent or life-threatening deterioration.
If they're like,
I think if you're giving that patient like IV cardine, then yes, that would qualify. If you just gave that patient a dose of their oral home blood pressure medications, I don't think it would qualify. No, this has never happened to anybody? No. We're almost done. I know, it's getting long. All right, so EKG interpretation real quick. So we were talking about this earlier. You need 3 of the 6 of these. So the rate rhythm, axis, intervals, ST segments, comparison to priors, or summary of the clinical condition. And again, you always want to make sure that you document your EKG results, right? Doing the EKG increases your medical complexity. Interpreting the EKG also increases your medical complexity. So it's like a 2-for-1. And then someone had a question, I think Harrison kind of related this along. What are the average number of RVUs per hour? And there really is no great answer to this question. When I was looking this up, I saw anywhere from actually, this was the range quoted in a lot of different papers and things was 1.8 to 2.8 patients per hour. If you go back to the 90s, I think it was much faster back then, and they were seeing between 3 and 4 patients an hour at some places. But I think the amount of work that we're doing in the emergency department and the complexity of our average patients are much more, or is increasing significantly since the 90s. So the numbers have slowed a bit. But that's a pretty big variation. That's a 33–40% variation. So really the better way to kind of understand where you are is to compare yourself amongst other people at your site. So if you're one of the faster residents in your class right now, you're going to be one of the faster docs probably after you graduate, and vice versa. But don't be hard on yourself your first year out of practice. I think it takes a while to get used to your new roles, and so you'll get continuously faster throughout your first year. At Rush, we actually averaged just shy. I was just looking at our data the other day. We're just shy of 1.5 patients per hour, according to our dashboard. But when I was at St. James, I was around 2.5 patients an hour. And I think if you're looking at sites for when you're looking for jobs, I think if they're telling you that they're seeing more than 3 patients an hour, I would want to know a little bit more about that. I think that's pretty tough to maintain a more than 3 patient per hour caseload.
I would say the averages are being per hour. This is possibly comfort out so they get on average complicated versus like so you have a lot more patient per hour, but less complex.
And even more than that, every site has a different average acuity. And here it's kind of broken down by state. And I've got the rest of the states on another slide if everybody wants to see where they're moving to. Right, but you can see in Illinois, average critical care is 8%. Level 5s is just over 50%. But you can see in wherever this is, Arkansas, their average level 5 is less than 50%. So it's different everywhere you go. So you can't directly compare patients per hour amongst different ERs, even if within the same city. And just in case you want to see the bottom half of the states. And this is just kind of an example. I try and stress in the class that you want your chart to be very easily readable. I don't know if that's the right way to put it. You want everything to be very clear how you have it laid out, because this is an old school version back when they used to use paper. Now it's all electronic, but they're basically just flying through your chart, looking to see which one of these they can cross off. So they see your stuff and they hit 4 checks up here in the HPI, and they get 10 checks in your ROS, and they knock off your medical history. They're just flying through this chart, or they're just flying through this document, getting everything done. So if all your stuff is easy for them to find, I think they're more likely to actually find it, if that makes sense. If you can imagine showing up to work every Monday with 1,000 of these things sitting on your desk. And that's really it. Thank you, guys. Do you have any questions? Cool.